many Kenyans as possible. When you say universal, hopefully we can get 100% of the people covered, but it's a journey, we agree with that. And today we are going to be discussing experiences and activities that KAPI has undertaken towards that direction. And to speed up the discussions, we are hoping, or we are using our admin point to run the shows. On your screens, I hope you can see your screens. We have shown the agenda for today. We hope to have a good 1.5 hours of solid discussions regarding this very important subject. My role will be to welcome you and also rapporteur, or not rapporteur really, MC the sessions, but the key voices we'd like to hear are shown here. We have Dr. Fred Sioi, we have Dr. Massimo Murangi, Dr. Eva Jenga, Mr. Anthony Murangi, Dr. Karim Bendau, coming from diverse backgrounds to give a flavor or a regard or a concern about why is universal health coverage significant and important. And for my role, later on, because today we are launching a publication that KAPI, with its global membership with IFPMA, has put together outlining the activities we are doing. We will do that towards the end of this discussion. But for now, let me give Esther, move to the next slide. Move to the next one. This is me. I have, I hope you can see me from the video as well. I have worked in the health industry for close to 25 years. I started my career with working with a small company. Later on, I joined AstraZeneca and finally closed my activities with Pfizer as at the beginning of this year. I'm still very well integrated into the pharmaceutical businesses as a chair of KAPI. Now, to all who may not be familiar or aware what KAPI is, this is a Kenya Association of the Pharmaceutical Industry. It brings together research-based pharmaceutical companies from across, or those represented in Kenya, multinationals represented in Kenya, plus some Kenyan research-based organizations that have been integrated as members. The key issue is our members take on healthcare challenges, disease challenges, or technology challenges, and work towards innovating solutions. And those solutions are geared towards improving service delivery one way or the other, but eventually they ensure proper breakthrough service to patients. And we've been doing this since the early 60s, and we look forward to collaborating with other like-minded people way into the future. Esther, please move to the next slide. Hello. And just to move, as I mentioned, we have international partnership with the IFPMA. And I do not want to say much about IFPMA. We have Greg Berry, who is the Deputy Director General, who will give us a flavor on this and also give more commentary towards the end of this of today's proceedings. Greg, welcome.
Really, thank you very much. And on behalf of all of us at IFPMA, we're delighted to participate in this event today, and very much looking forward to the discussions which are going to take place over the next hour and a half. Just very briefly, the IFPMA itself, of course, is the international organization representing the innovative R&D industry, both for treatments and vaccines. We have over 30 companies which are members, many operating on the African continent. We have 50 associations. We have 4 associations actually on the African continent. And we have 2 million employees worldwide. We're based in Geneva. We are integrated into the United Nations stakeholder system as a non-state actor. And our mission is to engage and promote the concepts of medical innovation and access solutions so as to improve people's health globally. And we have a specific Africa engagement committee. And I'm very glad that Karim is available to speak today, who is the chair of our committee. And we have a specific Africa engagement strategy where we're looking to increase the innovation and accessibility of medicines and treatments on the continent. Now, UHC is a key part of our policy advocacy. We seek a structured, a collaborative, a sustainable solution-based approach to UHC. We believe that UHC is key to patient access and to healthcare security. As an innovative industry, we're involved in various aspects, from the development of innovative products, investment and development in innovative products, as well as the manufacturing of those products and other established products as well. We're engaged in partnerships. We obviously provide high-skilled employment, which is an important part of UHC, as well as expertise in regulatory science. We encourage fully public-private partnerships to achieve UHC objectives. These can be from health literacy to health system strengthening to financial protection systems. We want to be, and we are, a key part and partner of the discussions around that. Now, there is no one-size-fits-all solution or model for UHC. These are developed according to national systems and priorities. They can vary from a public health, a national health service system with public funding and public-based servicing, to a series of private systems and employer complementary systems, for example. Innovation is only really meaningful if it is available to everyone who needs that innovation. And this is a collective responsibility. There is a private sector dimension of which we are fully engaged in the continent. And there is, of course, a very strong public sector responsibility as well from government, to provide the basis of the ecosystems for the private sector, as well as establishing the key aspects of universal healthcare coverage. I think finally, it goes without saying that this awful pandemic has emphasized even more strongly the vital need for UHC and for health system strengthening. And I think it is fair to say that those countries and regions where UHC and health system strengthening is more advanced, the availability and the outreach of vaccines and future treatments is more advanced. So it is absolutely fundamental, more than ever now, that we work together to achieve UHC on the continent, in East Africa, in Kenya, and to all the patients and people that we are trying to reach out to. So again, we welcome this report. We are very happy to be working with our sister associations, and we look forward to the debate today. Thank you very much.
Thank you very much, Greg. And our next comments will come from the Pharmacy and Poisons Board. And before I mention a little about the speaker, let me emphasize the value and the role played by the Pharmacy and Poisons Board as the regulator in the market. It is our foremost and first partner into reaching the Ministry of Health and reaching the patients. The role they play has often been misconstrued to imply a watchdog or a gatekeeper, but in fact, The Pharmacy and Poisons Board, as shall be probably emphasized by Dr. Sioi in his comments, it's a quality checkpoint. It ensures patient safety. It actually spurs innovation and the delivery of necessary medicines into the market through their own research. They advise and give signals as to what is necessary, what is required by the patient. So it is a multi-layered player, but the eventual outcomes that we all celebrate is quality of medicines, reliability of medicines, and patient safety. And to speak about the role of Pharmacy and Poisons Board in advancing access to universal health coverage, I'm very pleased to have Dr. Fred Sioi. Dr. Fred Sioi, I've known him for more than 2 decades. The first instance I encountered Dr. Sioi was we were struggling with how to achieve affordability in medicines some way back 1997 or thereabout. And the work he has put in, the commitment he has put in has been consistent. I've known him for 2 decades of solid input into improving access to health. Dr. Sioi, welcome and give us your view on the universal health coverage.
Thank you, Seron. The way you have introduced me is flattering. Do you get me?
But absolutely true.
Okay. Fine. So I'll not like to take a lot of time because I'm in a car traveling. And I'll just want to echo what you said about the Pharmacy and Poisons Board. We have a dual role. One is to make sure that the human resource that practices pharmacy is competent and qualified to do what they are supposed to do. But more importantly, is to check on the quality, safety, and efficacy of the medicines coming into the country. So you realize that we are a bit different from other regulatory authorities in the world, where they either concentrate on human resource or products. Us, we do both. So on this occasion, I want to thank KAPI and other industry players for the role they have played in trying to initiate and support UHC. I cannot overemphasize the role of UHC to the people of this country. You've heard of people paying millions when they get non-communicable diseases like cancer. And they die because they cannot afford. Will they sell everything they have or get treatment? And at the end, maybe it is not resolved. So they are left impoverished. So with the advent of UHC, we hope this will be mitigated. And I want to thank KAPI for cooperating in this effort. One, try to come with initiative to reduce the prices of some of the drugs for non-communicable diseases. Hypertension, our role as a board was mostly to fast track for you the registration. And even sometimes you've asked for waivers of fees, though it is not waived because we need a waiver from patient. So mine is to appreciate and to say I'm very thankful for being recognized and being invited to this occasion. I know I don't want to speak much on UHC because my boss, the CAS Murangi, is going to speak about it. I don't want to preempt. But I want to say that you as KAPI should not take your contribution as small. You've seen termites, the way they build on the head. They are very tiny beings, but at the end, what they build is huge because they keep working together. So I want to encourage you not to give up. You may feel your contribution is small, but at the end, it is not small. That small cumulatively contributes into something big. So I want to thank you very much for the launch of this report. And with those remarks, I don't know if my boss is within. I needed to introduce her and welcome her to make her remarks. Dr. Murangi, please.
Yes, I'm here, Dr. How are you,
Yeah.
Doctor?
Yeah, I think the floor is yours. Welcome.
Thank you. Thank you, Dr. Siri, and thank you, Dr. Sorine, for this invitation to join KAPI in the launch of this report. I see a very lovely picture on the screen. I'm not sure, I think people will read and I'll jump into our discussion. Is that okay? Sorine, is that okay?
That is indeed okay, madam.
Thank you. Thank you so much. Let me begin by also thanking Dr. Siori. Indeed, he has been a major pillar when it comes to pharmaceutical services and interventions within government, and we continue to work with him and appreciate his support to this cause. When I saw the invitation from yourselves on UHC, I was quite excited because this is what you'd call my baby or pet project within the Ministry of Health. And I'm quite humbled to see that KAPI is part of this and is making contributions to this. But even more importantly, that KAPI has taken the time to be able to do assessments and reflections on where we are with the UHC journey in the country. And so I thank you so much for that work, KAPI. This is quite fantastic, and I will actually be relaying this report to my seniors, for also their indulgence in terms of what your findings are. And so let me begin by saying again, it is my pleasure and honor to join and preside over the launch of the KAPI report on UHC. And I must say at the onset that the approach by KAPI to support government's initiative towards UHC is a welcome move. I'm pleased, and I've heard our previous speakers, Mr. Perry has talked about the need for collaboration, and he's really emphasized that. And so to be here today with yourselves as KAPI discussing UHC is quite pleasurable, and we're very happy to be part of this. And indeed, more and more collaboration is required in all stakeholders and actors in the health space. And of course, recognizing that really UHC is a journey, and to be able to achieve the objectives of UHC, we need to work together. We all know the relevance of UHC. We appreciate it is a pillar of the Big Four agenda. And every nation in the world, I'm sure at this point, particularly in the global health space, recognizes the role that quality health services serve when it comes to ensuring that a country can develop socially and economically. And so most recently, about the end of last year, His Excellency, the President, Uhuru Kenyatta, was able to launch the biometric registration of indigents as part of the UHC program. And if you'll allow me, I'll paraphrase his words during that launch, where he said that our dream for prosperity and better health will remain hollow, and I really emphasize on the words hollow, if we do not give priority to improved standards of health across all cadres of society. And therefore, it's really important, and those words made me reflect, because I think right now, there's not a single soul in the global health space, and even in the public health space, who doesn't understand or appreciate or support UHC as an initiative. And so therefore, as we congregate today as KAPI, perhaps the question is to ask ourselves, even after having all this commitment, are we able to meet the mark? And I'm hoping this report will be able to identify what are those matrices of improvement that are needed, be they quantitative or qualitative, that will move us towards achieving UHC. We do appreciate, therefore, this ambitious initiative in light of all the challenges that we are facing as a country. And we are cognizant of the fact that achieving the goals of UHC may require major sacrifices in other competing sectors of the economy. And this is definitely a journey that we'll be walked towards progressively. Now, a little side note here in our discussion today in terms of the history of UHC in the country. I was quite humbled to learn that this was actually one of our forefathers' agenda. If you all remember the paper 1962, if I'm not wrong, on Pan-Africanism, it talked of eliminating disease in the country. So this goes way back when to the beginning of the country in terms of independence. And so different governments have come in and put in place different initiatives, all with the aim of ensuring that there is universality, in access to health services, and that these health services are of good quality. Where we are right now, speeding forward more than 50 years, is that about 2 years ago, Kenya was involved in a UHC pilot program. And this was an initiative that was undertaken with county governments and the Ministry of Health to be able to provide health services to about 3.2 million people in 4 counties across the country. And the idea really for this pilot was to study and try and understand what are those necessary inputs when it comes to delivering a health service. And so there was a lot of working and design towards provision of drugs, and a lot of work towards looking at human resource and other inputs that are necessary for delivering a health service. And together with this, perhaps I can say the most fundamental lesson that we learned was the need to ensure that such a program is sustainable. And so it was soon determined by the end of the pilot that perhaps we may need to transition from input financing to output financing, where we focus more on looking at how to finance the architecture and to almost, if I dare say, nudge both the health worker and the patient and the system towards better health outcomes. And so where we are right now as a country is that we are in the scale-up phase of the UHC program. And what it looks like right now is that we have about 1 million households who've been registered through NHIF. And this 1 million households will be able to receive a UHC card where they're able to access services through NHIF and access a certain benefit package. Now, what is even more exciting is that as government, we currently have the NHIF bill that is currently going through the due process in Parliament. And the idea is that the NHIF bill actually enshrines the concept, the logical concept of UHC in the country. And the idea is that future governments, including this one, will be mandated to ensure that UHC interventions, activities, the merits of what it means to actually provide care for the whole of the country's population are adhered to and are resourced, both technically and financially. And one of the big moves in the bill is that we shall actually mandate engagement in some form of prepayment, some form of insurance, with NHIF being the key implementing agency. And so as government, we have put in place this year 6 billion Kenya shillings that will go towards the payment for this 1 million indigents who've been registered. When we look at our targets in terms of who we need to capture, the people who are in need of these subsidies, we have about 4 million households as our target. And so progressively, government shall continue to put in place these resources. And particularly after the passing of the bill, I dare say government will be mandated to ensure it covers all poor households in the country. And then, of course, the other members of society are expected to be captured through the other normal processes, statutory deductions, and such like processes. And as we continue to do this, I think I have to emphasize a key element here of partnerships. And we began with partnerships with Mr. Perry in his introduction and his remarks. And I think, again, this is a juncture where we need to emphasize it, that even as we work towards this UHC program, we recognize the role of private medical insurance industries, but also, of course, other side, and should I say, ancillary industries, such as KAPI and your members who support this agenda of UHC. We've had good success in different collaborative efforts with some of your members. Some of your members have come forward, and I'm glad to see Novartis is here to share their experience of UHC and how they've supported it. We've had different pharmaceutical companies put in place access programs with KEMSA, access programs with NHIF. And more it's becoming imperative that this collaboration between us and the pharmaceutical industry is perhaps very crucial and a crucial nut and bolt towards achieving this UHC goal. And so we do recognize the KAPI, the International Federation of Pharmaceutical Manufacturers and Associations, its members, and all stakeholders for their efforts in championing innovations in the biopharmaceutical industry. It would be remiss of me to end without sharing with you one of the key agendas that my cabinet secretary holds, which is local manufacturing. I think one of the biggest lessons we've learned through COVID-19 is perhaps the understated need of self-reliance. I do remember a time last year, heavy and high at the peak of the COVID-19 pandemic. As government, we had the resources we needed to be able to get PPEs. However, we were simply unable to source them because every country, was trying to secure the needed supplies for their own use. And so this spurred a thought in government, this spurred a thought in the cabinet secretary's mind. And so one of his agendas, which we are supporting, is that of really investing towards local manufacturing. As a country right now, one of the key things that I'd be interested to perhaps take forward with yourselves as KAPI and with IFPMA is the whole idea of vaccine manufacturing, along with other products and technologies that are needed. I think if you followed the president, you will note that currently he is on a mission in the coastal part of the country where he's launched a few initiatives in health that touch on local manufacturing, including manufacturing of malaria diagnostics and other elements that are supposed to support the fight against malaria. This is to be extended towards other areas in the country. We do have our gazetted list of items which we intend to procure from local manufacturers within the country. And so really there are many spaces for collaboration, for fostering learning, and for really improving quality in what we do. I am also aware that there are different other initiatives that are underway, particularly with the Ministry of Trade and Industry. We do have plans underway to put in place a pharmaceutical park at Konza ICT City. And so there's a lot happening in Kenya with regard to these spaces. And really, this is something that I would say is a pet project for Waziri, and he's really putting all his energy towards it. And so we need you to come to us and really walk this journey with us. This is an open invitation for you to do that, Dr. Sorine and IFMA, so that we can perhaps, make some gains when it comes to really fostering self-reliance in the country, but also ensuring that these medicines are available, affordable, accessible, and that they're safe and efficacious. Thank you so much for your time. I'll hand over back to you, Chair.
Thank you very much, Dr. Murangi. That indeed was very comforting to see the progress the government has made. It has stayed true to the journey to achieve universal health coverage, and the most notable that you have mentioned here is first the shift from input to output compensation in insurance services, in the NHIF services. That would be wonderful, because then you're paying for outcomes, you're paying for results. We are using every Kenya shilling we have to achieve the results we desire. That's really lovely. We've had a look at the NHIF bill as KAPI. We think it is, as it does not take away the desire to ensure that we are very happy with that bill, and we look forward to continue the partnerships. I must say with pride now at this point that the success we have encountered in the 4 counties that they're on enabling platforms developed by KAPI membership. If you recall, MTBA has been at the core of that piloting, and with much on through our member company, Pfizer. Next session now, and have our next presenter. Back to the screen. So my next, our next presenter or speaker is Dr. Eva Jenga. Again, my journey and working with Dr. Eva Jenga goes beyond two decades again. This is a very passionate individual about, especially when no one thought diabetes was a problem. Dr. Eva Jenga was up and down the corridors and the roads, trying to bring attention, bring knowledge, bring resources into the diabetes care. And I remember the first institution that she was affiliated to was the Kenya Diabetes Management Institute. That was way back, maybe 15 years ago. And her commitment has not waned. I'm very happy to have her present to us the case of universal health coverage from the perspective of patients and from the perspective of the National Non-Communicable Diseases Association. Welcome, Dr. Eva Jenga. Dr. Jenga? Esther, do you know whether we have Dr. Eva Jenga online?
Yes, she is. She's online.
Yes.
Dr. Eva, can you hear us?
Hello?
Okay, good.
Yes, we can hear.
I can hear you, then you drop off. I don't know whether it's my internet because but I can hear you now. Hello?
Okay. Please, welcome.
We
can hear you.
Okay.
Yes, please, I can hear you.
There you go. Thank you so much, Willie, for your kind introduction. I wish to recognize all the other panelists, all protocols observed. My cast, who is part of my partner's memories, Dr. Murangi. I really appreciate what you have said and encourage that we are moving on with the UHC implementation. Greg Perry, thank you so much. IFPMA and KAPI have been key supporters of the work that's going on in Kenya from as far as the society, our NCD society is concerned, and from the patients' support. I know Willie is making sure that medicines and supplies reach the patients at the right time and cost effective, and I appreciate that. And of course, Dr. Siri is my neighbor and a regulator. We work very closely together, and I really do appreciate that we are able to join hands and resonate in matters health and the regulation of health. So today, Dr. Murangi, if you hear me challenging you, today I'm actually voicing the patient's perspective in as far as the progress towards universal health coverage, as we appreciate the report of KAPI, who is a key partner. And I'm coming from Non-Communicable Disease Alliance of Kenya, where we are an umbrella of many organizations, patients groups, NGOs, CBOs, and professional associations. And we are involved in advocacy, prevention, control, and rehabilitation of persons living at risk of or living with non-communicable diseases. We have one vision. I know it is what you're telling me, that's a dream, an NCD-free Kenya. But we have to dream big, and we usually say all dreams are valid. And I think if we put our best foot forward, we will get somewhere, and at least we'll see something positive. And listening to Dr. Murangi and where we are at with the UHC implementation, I feel encouraged. At some point, from patients' view and the kind of voices that we hear, is that we feel that some people are being left behind. So next slide, please. So how do we, WHO describes or defines universal health coverage? We want a situation whereby we have equity in access to health services, and the entire population is covered, not only those who can afford the health services, meaning that people will get quality health care and not risk becoming or being driven into poverty. And again, no one should be left behind. And from Non-Communicable Disease Alliance, we know that for the longest time, the NCDs have not really come up to the level where you'd expect them to be either closely or at the same level with communicable diseases. And this is not just in Kenya, this is global. So we really have to step up our voices as patients and as advocates for patients, people living with NCDs who may not even be patients as such, but they have disabilities and comorbidities. So we know for a fact NCDs account for more than 50% of hospital admissions in Kenya and over 55% of hospital deaths. So this is something that you can no longer ignore or shut your eyes towards. So the Universal Health Coverage Program we saw when it was piloted in 4 counties, that's Machakos, Nyeri, Isiolo, and Kisumu for 12 months. And we have, a number of us have been in CMEs, we've been on webinars, we've been on platforms, workshops, where the reports have been presented. And we do know the challenges and the lessons learned from that pilot. We also know that, and Marcia, you have said the biometric registration has already been launched. What we are worried about as people living with NCDs is that we need to know whether the people living in NCDs are being represented well, the age groups, and who is going to keeping a track and evaluating whether they are being they're among the 1 million that are going to benefit from this initial 1 million team that we have mentioned. The NHIF especially needs to really be aware that the NCDs, of course, there are so many, and you can't say that you need to go with the 4 major ones. Every NCD counts, however small some people think they are. So they need to be thought of, and NHIF has to have a criteria where it has a package without singling out diabetes or hypertension or cancer or any of the other things that we think are major, that if you come with an NCD and is diagnosed as NCD, it falls under the criteria of that health package. This is what the patients are saying. This is what the people in the support groups, the people living with NCDs are saying. So the people also who are older with disabilities, they need to be involved in all the benefit lineup, like the cash transfer programs, to be able to purchase the insurance coverage through NHIF. Next, please. Next slide, please, Esther. I want to give you an analysis of some focus group discussions we've had with our patients. One, the women said, we used to experience absence of drugs in public health facilities and NHIFs. Additionally, we lack proper nutrition with NCDs, and this is from a woman who gave us that. Then for the men, the focus group with men, this is what they said: we experience various challenges. This diagnosis of NCD conditions has resulted to an increased drug load, which is very expensive. Lack of jobs by some of us has led to lack of income. Again, which has impacted negatively on our access to services. And I know quite a number of farmers are really looking for I'm sorry, team, I don't know. I think I'm in my clinic and it seems to be
Recording in progress.
Hi, Esther. Have we lost Dr. Eva Jenga?
Yes, I think Dr. Eva has dropped off.
All right. So what do we suggest? We proceed with the program as we wait for her, or we give her waiting?
I think we can proceed and have her when she comes back.
Okay. Can we go to the next slide for the next speaker then? Hello, Esther. So as you are looking for the next speaker, let me just, to the audience, recap some of the things that Dr. Eva Jenga has said, even though she did not cover her presentation completely. She's talking from a patient perspective, which is what do the patients experience really? As we discuss these things in the planning rooms, in the boardrooms, in the meeting rooms, what is happening on the ground? And you can see there are some clear challenges that are happening. And we do appreciate this, and we hope that as we continue running forward, the UHC ambition, even though it was stated by our forefathers, it is hardly 4 years old after being relaunched by the president, and a lot of teething issues will emerge. We're very happy that she has outlined the need not to leave behind people living with disabilities, especially when biometric registration happens. They can easily be left behind. And also the concern, their big plan, the big-hearted plan to achieve an NCD-free Kenya in the coming future. I think when we get her back, we hope to hear a lot more from her story. But for now, I am very pleased to introduce or to bring our next speaker, who is from Novartis. Let me not introduce Anthony himself. He will introduce himself to the extent he wants. But I say something about Novartis. Novartis has lived and walked the mile with regards to advancing access to health, not even necessarily under the UHC itself, but it has lived a large spirit in advancing access to medicines, especially by those left behind. And the flagship programs they've done in the past includes bringing the appropriate malaria treatment to the availability and access to the majority of the populations. You do not hear a lot of deaths in malaria nowadays because the documented evidence shows that malaria has dramatically gone down. It's largely because of the efforts of Novartis. Further, they've entered the non-communicable disease space and supported access to hypertension and cardiovascular treatments in a large scale that is really embodying the spirit that KAPI has been championing for long, to say, we want to make medicines available, good quality medicines accessible to all, but not to To interrupt his presentation, let me welcome Dr. Anthony Murangi to give us the view from Novartis itself. Bwana Murangi, karibu.
Hi, Willie. Good afternoon. You can hear me?
I can hear you very well.
Great. So good afternoon, everyone. My name is Anthony. As you can see on the screen, without going too much the details, I think myself and Willie, we've been colleagues in the pharma industry for the longest time. I've done about 2 decades. Willie has done a little bit more than that. But yeah, that's Anthony, and I've worked in different companies, generic companies, AstraZeneca, and more recently working in Novartis as a cluster head for Novartis here in East Africa. I would like by, first of all, acknowledging the presence of CAS Health, Dr. Massimo Agangi, the KAPI officials, IFPMA, and all presenters, and more importantly, all the industry colleagues on the line. I have 10 minutes to share with you a brief presentation to demonstrate what Novartis is doing as we strive to partner to advance universal health coverage here in Kenya. And I know I have only 10 minutes to do that, so I'll try to be brutal with time. Esther, if you could move to my first slide. Yeah, that's basically myself with a small picture. But going straight to my presentation, I think I'll start by giving you a glimpse of what Novartis is all about in terms of our purpose. And clearly, we are striving to be a courageous and a trusted healthcare partner. And our mission is definitely to improve and extend the lives of people in Africa. That's the ultimate goal. But for that to happen, we have also defined very clear priorities that we are putting a lot of time, energy, and resources behind. The first one is broadening access. And I think this is very much in sync with that aspirational ultimate goal of driving and advancing universal health coverage. And our very simplistic definition of broadening access is getting Novartis product into the patient's hands in a timely manner. So very, very important. Product in patient hands, and then the time element. The second one, our second biggest priority is building capability. And why we feel this is very, very important is because we all know that patient accessing medicine comes at the tail end of a patient journey. Before ultimately getting a pack of whatever product for whatever disease a patient is being treated for, there's a journey behind. And on that journey, there's the whole discussion around disease awareness, for example. And I know most people in this part of the world, our health-seeking behaviors are not very good. Most people, especially with non-communicable disease, they are walking along the streets without the knowledge of the underlying problem. So we are very keen to do a little bit more in the disease awareness piece. As I speak to you now, I have a team of Novartis in Taita Taveta, driving some community engagement on some specific disease area to create awareness so that then ultimately they can seek healthcare intervention. After that, then we want to go into the diagnosis and screening space. Another big gap in our healthcare system, and that's where our building capability piece comes in, because this can be in form of both the infrastructure as well as the skill set. So Novartis is definitely doing quite a bit of work to support, especially the healthcare providers, different cadres, to enhance their capacity to accurately diagnose patients. And ultimately, then we also want to shape the environment, which is our third key priority. And for this to happen, internally, we've committed to remain leaders of doing business, with integrity. But we're also very, very keen to work with other like-minded partners to make sure we shape the environment within which we operate the best way possible. And underpinning these 3 priorities then is the operational excellence piece. And with this, we have very committed partners that import Novartis product from different parts of the world and make them available in our market for our patients in a timely manner. Esther, we could move on to the next slide. Yeah, so when you talk about access, I think that's a big subject. So we are looking at 3 access basics as Novartis. The first one is patient access, access principles, and the last one is access programs. So under the patient access, I think the big focus here has to be on getting the right patient and then the right diagnosis, right treatment. Very, very important, and at the right value. I think there's a whole subject about value price. I would say the right value. Then when you talk about the access principles, as far as Novartis is concerned, we definitely want to leverage on our access principles of adopting innovative access models, targeted research. This is very, very important. As a matter of fact, we do have a number of research programs, happening even here in East Africa with between partnership of Novartis and researchers within the region, and ultimately strengthening our healthcare system. I think COVID has exposed the weaknesses in our healthcare system, and we really need to join hands to enhance that particular piece. And when you talk about the access programs, which I'll be speaking a little bit more on later, there's a lot that need to be done to make sure, patient with, non-communicable diseases, which Dr. Eva Jenga has rightly mentioned, the burden of disease in terms of the stress non-communicable diseases are putting on our healthcare system. In terms of hospital admission, 50%, that's huge. Mortality about 55%. This cannot be, overemphasized, but a lot need to be done in the non-communicable disease. But also we have neglected diseases, like Chagas, leprosy, sickle cell disease, and even malaria, for example, which Willie was talking about. And the ultimate goal here is to enhance access of life-saving medicine, especially to low and middle income countries. And that's exactly where we sit here in East Africa. Esther, we could roll to the next slide. Thank you. So our access principles address 3 key things. One is, if you look at the triangle at the center, we have at the base research and development. As an organization, we are very, very committed to, still pumping a lot of investment in that space, both for today and the future. Then the next one on the other side is healthcare system strengthening, which I've already talked about. And ultimately at the top, bearing in mind affordability is a key driver of success in this part of the world. So as Novartis, as Willie has mentioned, and I'll be able to demonstrate that in my next slide, Novartis is doing quite a bit to drive the affordability piece to make sure as many patients as possible. Actually, our mantra is that we don't want to leave any patient behind. So I was very happy to hear Dr. Eva Jenga, repeatedly talking about the need not to leave any patient behind, and not only at the peak of the pyramid. This time around, we are looking at the entire socio-economic pyramid, from the top, medium, as well as at the bottom of the pyramid. But we cannot do this alone. We need all hands on deck. We need the government, we need the private entities, we need the pharma companies, we need international organizations, the payers, the insurance companies, to come on board to make sure that these 3 critical pieces on my triangle, on my pyramid here, are in place so that we can all talk about driving access of quality medicine to our patients. Let's go to I believe my very last slide, and which is the main highlight of what Novartis is doing to support the government in driving in achieving the universal health coverage. So these are glimpses, not everything that Novartis is doing, but basically to give you a glimpse of Novartis access programs, including innovative flagship programs around malaria. A lot has been done in that space. I think everybody you meet on the street of Nairobi or up country knows Coartem, for example. Sickle cell disease, which has, in my opinion, been neglected for quite some time, leprosy, as well as other diseases like Chagas. So there are about 5 of them that I wanted to share with you this afternoon. And the first one is the Interlife Kidney Transplant Program. And this is a partnership program between Novartis and Kenyatta National Hospital in conjunction with a team of specialists from Barcelona. It has been running for a couple of years. And the whole idea here is to enhance the capacity and skill set of our doctors and our nurses so that they're able to carry out kidney transplants, as many as possible, from Kenyatta National Hospital, which we envisage should become a center of excellence for this particular procedure within East Africa and beyond. And our key success highlights, you see there is about more than 215 kidney transplants have been conducted under this Interlife program, with patients benefiting from innovative medicine from Novartis. And we are planning to scale this, moving into the future, and we invite like-minded partners to join us with this one. The second one is Novartis Access portfolio for non-communicable disease, which Willie was alluding to, and mainly looking at areas of diabetes, respiratory, and breast cancer. And very, very important to note is that Novartis has availed a long list of products at a cost of $1 per month treatment for the patients. We piloted this through MEDS, and it's taking a good shape, and we should be able to scale it up to other entities, including government and other NGOs and other institutions. The other program which we've been working on is the Novartis Global Health Sickle Cell Disease Flagship Program. This one is recently new, started in 2019. It's focusing on 10 countries within Sub-Saharan Africa. Important to note is that 80% of patients with sickle cell disease, they're in this part of the world. And very not interesting statistics that 50% of the children with sickle cell disease usually die before reaching the age of 5 years. And Novartis, we are very, very committed to change this narrative for our kids. So basically what's happening in this space, we've started key initiatives, including some research work, which is ongoing on a very, very innovative treatment option for this patient. Capacity building initiatives are ongoing. We've trained a big number of healthcare providers. You see now there are about 2,700 already trained. We're also supporting the diagnosis and screening piece that I talked about earlier as a critical piece of the puzzle if you look at the patient journey. And recently we donated a biochemistry electrophoresis machine to one of the center in Madare somewhere along Bika Road for the purpose of accurately and timely diagnosing patients with sickle cell disease. The fourth key initiatives we've been working on at Novartis is the cancer therapeutic, cancer treatment access partnership. And this one, it's very, very new partnership between Novartis and the Clinton Health Access Initiatives, where we are providing a list of 17 treatment options for breast cancer, prostate cancer, and cervical cancer at a very, very modest cost. Very new, and again, we invite as many partners as possible to join us on these initiatives so that as many patients with these 3 cancers or even more can benefit from quality medication at a timely manner. Last but not the least, we have the CML treatment access program. This is for patients with blood cancer, chronic myeloid leukemia, and the program is called JIPA. We've been driving it in partnership with the Kenya Association of Oncologists. Mainly, the main center is in Nairobi Hospital. We've treated many patients with the Glivec product from Novartis. Some of you could be aware of this program in partnership with the Marx Foundation. About 10,000 patients treated. The program is still ongoing. A couple of weeks ago, we also supported the Oncology Association with some resources to put up a registry, because some of these programs, they've been on for some time, but there's no data. And ultimately, we need data on the table to inform our policies, inform decisions, whether from the government or from association or from partners. So that is ongoing. Let me say, these are glimpses of the many things that we've been working on as Novartis. And it's clear that we've done some good work, but more work needs to be done. And for more that work to be accomplished, partnerships becomes the name of the game. We are talking about our mantra of not leaving any patient behind, and looking forward to having continued discussions, continued partnership with like-minded entities as we strive to drive access to universal health coverage in Kenya and indeed beyond Kenya into the region. Back to you, Willie. I think my 10 minutes should be over by now. Hello? Esther, do we have Willie on the line?
Yes.
Yes, I am back.
Yeah, thanks.
Sorry,
Willie.
sorry, my connection dropped. I hope you can hear me well.
Yes, I can hear Willie. I'm handing over the session back to you.
Thank you very much, Anthony. That is indeed the spirit of ensuring no one is left behind. I am very happy to hear the initiatives that are coming from Novartis. And by no means, this is not unique to Novartis. This is the work and effort that every company in KAPI is pulling through. And if we were to enumerate all of them, we would sound like we are bragging. By all means, we are just celebrating the success that we have achieved to support the patients and ensure that equity is achieved one way or another. If there is no institutional framework of driving that equity, that is before the president set out the UHC, the KAPI membership was already running the same. And at some point in the future, I hope to narrate one or two, but to speed up with time now, we'll go to our next speaker. I don't know whether we have Dr. Eva Jenga back.
Yes, I am back really, and I was almost,
Yes.
I had one or two slides remaining, so I
It
can
would be very
quickly go through that. Yeah.
Please do, yes, please do. And then we go to an AMREF report.
Yeah. So Esther, please, can you go back to my presentation? But I'm really, really excited, really, just listening to Novartis. You just feel encouraged that these partnerships and all the pharma who have provided access programs for various treatments, both communicable and non-communicable. This is really is admirable. And as Kasmagagi said, partnerships, there's nobody who can do anything alone. We all need to join our hands, and we might see a successful UHC implementation if we all pull together. So I was talking about the the shortcomings of the pilots that came out. We did when people had that universal health coverage, meaning that everybody was getting health services for free. The queues were so long. The health facilities and health workers were actually overwhelmed. Most facilities ran out of drugs, and it was really unfortunate that the information that went out as to what UHC is, maybe we didn't even know what we meant by UHC, because everybody thought now this is free laboratory, free X-rays, free everything. You go and get that. And of course, the way the economics of scale, the cost of healthcare, I don't think any government, without a backing of an insurance services, it won't work. And so much what the NCD Alliance is doing is creating awareness among the members that everybody should become part and subscribe to NHIF. So I think this is very, very important that with the kind of challenges we got from the UHC pilot in the 4 counties can go into good use, and we can create a better understanding what this universal health coverage means. And this is why even getting to the indigenous, we know there are more than 1 million, but the government will not do this. So we need to advocate for more people to join UHC. Next, please. So the cornerstone for achieving universal health coverage for us in Kenya, and also as we see it as patients living with the NCDs, is to make sure we have accessible health services, to reorientate, we'd advocate for orientation of health services to ensure that care is provided at all levels. Affordability, that goes without saying, and this is why we are having members of KAPI, and of course we are joining hands with the government to make sure that we get affordable health services and health care and health delivery and drugs. And of course that the supply chain remains strong. And we need to seek for alternative venues to fund UHC in case, of course, there are many people who are unemployed. Where you are employed, the employer is supposed to remit your NHIF contribution. That will be the platform. NHIF is going to be the platform for UHC implementation. The availability of NCD supplies, this is what KAPI you've been talking about, and your members, really, all those access programs that all the pharma are contributing is to make sure that the medications, the drugs, and even other supplies reach the people that talked about training of healthcare providers. And this is very, very important, including community health workers and volunteers. We feel that even as a society, empowering communities to take responsibilities of their health in way of talking about risk factors will definitely make UHC affordable when they are, but they also come to be checked to know that they are well. Accountability is key. Social participating through meaningful involvement of people living with NCDs. And we have realized that the support groups that involve the patients, they are our best and strongest voices to set the messages. It's where you should even pilot all these access programs that you have, and its uptake really will make you, your whatever access program that we offer, it will make it successful. If people know what it is that they are being given, and for them to know that it is for them, instead of just something being dropped on them. So creating awareness is very key. And of course, credibility of the institutions that people living with NCDs are looking up to, the Ministry of Health. They look up to you to be the advocates for them. And of course, KEMSA, all the things that appear in the media, people living with NCDs wonder who is for us, who is going to give us the support that we need. NHIF has to, and I know now with the organization and the structuring of NHIF is giving some kind of hope, and that's what we need to create for our people. We have many, many opportunities, and which I've mentioned quite a bit. I won't go through that. The one I really want to mention is leveraging on our key partnerships. I think this is so key, and in a way, find ways, even through our partners, whether we are in private, public, faith-based, or in the communities, let's track and evaluate how we are doing, because that's the only way we'll know whether we are successful. That's the only way we will know who is being left behind and why. And this COVID has taught us quite a lot. When people don't come even for their health reviews because they've been told you have comorbidities, you can't come. I think we need to put digital systems to be able to track where our people living with NCDs are, and they'll be able to give us a feedback, which then will inform policy, and we get advice on how to make sure essential services are delivered. So this is important. I would want to say that even as COVID-19 has been highlighted, that it's one of the things that has caused a lot of stress on people living with NCDs, it has been an eye-opener and given us a chance to restructure the way we manage our health services. So next, I think is my final one. Last slide. Yes, that's actually where you can find the NCDAC in case any of you want to partner with us. We already have quite a number of the pharma that partners with NCDAC, and I think let's continue, because together we are stronger, and I'll join Novartis in the same mantra: we shall not leave anybody behind. And the people living with NCD continue saying don't make any decisions without us being on the table, because we don't want to be the food on the menu. We want to be part of the people who make that menu. Thank you very much. I really appreciate having been requested to come and voice the views of people living with NCDs. Thank you, Willie, as always. Thank you.
Thank you very much, Dr. Eva Jenga. That indeed was more than we would have needed to understand from the patient's perspective. If I summarize what Dr. Eva Jenga has said before we go to the three takeaways, when she's speaking from the shoes of the patient, was one, engage the communities. Don't make decisions from the boardrooms alone. Yes, there's a lot of learning, all technical expertise and all that, but hear the voice of the patient, engage the communities. Leverage partnerships is a major point she's made. And we can see that based on the experiences we've had, partnerships help us to leapfrog problems rather than take the long road and the winding journey. If we partner, we move faster. And also, she has duly and very well emphasized tracking and evaluation to ensure that no one is left behind, and not work on illusions or assumptions that we've done a good thing. Will the tracking and evaluating confirm it? That is the message from Dr. Eva Jenga. Thank you very much. Now, let me invite Amref to give us a view and a message around universal health coverage from the Africa perspective. Welcome, Amref.
Hello, good afternoon. Yeah, my name is on the screen, and I will, and for the sake of time, I mean, I will shorten a bit my talk. And we'll really look at how the private sector can help in achieving universal health coverage. During this AMREF working group, and I was one of the commissioners, we came out with a very good report, I think, very exhaustive. So it's already online, and you can, by clicking on AMREF internet site, you can download the report and read all the recommendations. But most of you, and I already noticed that, are extremely familiar with the recommendations of this report, and also familiar with the principle of the universal health coverage. Therefore, I will not go back on this, but I will focus a bit on the role of the private sector, which has been discussed during this very long sessions of the AMREF USC report. We see more and more governments engaging with the private sector, and today I noticed that Kenya is really very advanced in that, to identify common interest to foster a new partnership for universal health coverage. We agree that before getting into partnerships, which is normal, with the private sector, regulatory processes such as legislation, monitoring, and compliance need to be in place. It's not the case in all the countries. And we agreed also that the private sector is not the problem of the USC, not even part of the problem, but it is a part of the solutions. Governments, again, need to create ecosystem from training of youngsters, regulatory strengthening. You see AMA progressing fastly, and yesterday we got very good news. 15 countries have already ratified the treaty. That's very good. And then the industry can create a dynamic solution, create employment, economic progress and development, and create availability of health products. Neither side can work properly if the other does not. And when I'm mentioning the private sector, I'm mentioning both the non-profit private sector and the for-profit private sector. And we strongly believe that the biggest mistake in pathway to Africa UHC is to think that only public sector and civil society, it's only public sector and civil society driven. It's in reality a strong and solid partnership, government, communities, private sector, and in the center, the UHC. I mean, even if it is a bit surprising for governments, I would suggest that we should profiting from profit organization and aligning private sector interest with UHC. A holistic map of the health system, which include the private sector, can reveal new opportunities to accelerate the progress in service delivery and reaching UHC. First of all, we need to change, changing its vision from a mono to pluralistic health system. Strategically deciding what the private sector's role in this mixed health system will be. Third, building state capacity to creatively and effectively use a policy, financing system and processes to harness and leverage the private health sector capacity to support. I mean, this all the discussion, during this committee also of the AMREF related to the role of the private sector, we really say that the public health, this discussion of public health versus non-public health is unhealthy discussion. We also agree that we, biopharmaceutical companies, agree about the importance of the framework for appropriate interaction and to build also the trust. The pharmaceutical industry is very well regulated, and you know that, and KAPI, you know very well this, my colleagues there, and it appreciates really regulation to ensure the patient to get the quality drugs they need. The private sector, again, believes in collaboration and is very well trained for that. We are ready today in 2020. To build on and maximize the private sector existing contribution to ESG, we need first to offer a quality of product and services that consider the needs of all the people, including poor and marginalized population, and make this affordable, accessible, and sustainable. And my colleague from Novartis in the previous presentation and talk, he clearly shared that. The private sector being a significant provider of products and services in most of the countries, this core offering and demand-driven products and services is its greatest contribution to the UHC. From the side of the industry, incorporating UHC principle, including to leave no one behind in core business model and objectives. This may include, for example, looking beyond immediate results and taking a long-term approach to business goals and impact. We need to be consistent in supporting development of resilient and sustainable health systems. The same principle also apply, well noted, the same principle also apply to any philanthropic or charitable industry. Third, develop, test and scale up innovative business model that align with UHC. Innovation can happen on many levels, especially in approaches that help to drive greater and more equitable access, quality, and sustainability of health product and service offerings. Last but not least, that's the leapfrog: create, adapt, apply, and scale up innovation. Private sector innovation is an engine for new products, techniques, and insights that can improve healthcare, strengthen health systems, and increase efficiency. Digital health can be game-changing for health system transformation. New technologies and approaches can help countries to leapfrog along and development pathways and rapidly accelerate progress toward USC. Engage in, champion, and build capacity for relevant policy, dialogue, and partnership with governments and other stakeholders. This is fundamental for identifying shared objective and developing collaboration. And my usual recommendation and sentence: health is not a cost, it's an investment. Thank you. I will stop here because I've been asked also to. Thank you very much.
Thank you very much, Dr. Karim. Dr. Karim carries a tough name to pronounce, Bendao. But he delivers a very simple message, which I will not dilute other than just repeat his last sentence. Health is not a cost, but an investment. And as a private sector, demonstrated by KAPI, we will continue playing our part to ensure that we attain that reality. Maybe one thing that needs to be done regularly is to define what is private sector. There is always this feeling that private sector is an entity that exists out of a dimension. Private sector is basically the enterprise arm of the society. So we are all private sector. We may be public sector during the day, but at night we may be private sector during the day, but at night we are all public sector. We are one. Thank you very much, Dr. Karim. And going now to our next session, let me request all our audience that we are running behind schedule, largely due to the richness of content and very insightful discussions. As we go now, let me go into quick launch of the publication. It's the launch is basically to hand over the report, capturing all the activities and collaborative elements that KAPI has engaged in. It is not exhaustive. It does not even reach exhaustive, because the depth and breadth of activities and investments that KAPI membership is doing to advance access to health in Kenya and Sub-Saharan Africa is awesome. Now, please let's go to the next slide. About 4 years ago, Kenya made a strong commitment, and it said it wants to advance universal health coverage. Now, this was a package of the Big Four agenda by the president, and these Big Four agendas are largely social development agendas. We've previously emphasized infrastructure, technology, but then the president scaled down and said, let's also expand the social fabric of the society through prioritizing food security, affordable housing, manufacturing, and accessible healthcare to all. And this is the reason we are gathered today to celebrate or to highlight some of the activities that the KAPI membership has done to help transform Kenya into an industrialized country by 2030, but from supporting the health perspective. Next slide, please. I wish I could let Lea Kilenga herself state this, but let me give each of us 10 seconds to read this for yourselves so that I do not dilute its impact. Right. So this is speaking to sickle cell, and you would know how not intentionally marginalized, the sickle cellers are, but the health system somehow, universal health coverage is nothing but ensuring that people like sickle cell patients are not left behind. There is a and as I'm moving to the next slide, I reflect back on the work that our member company Novartis is doing towards the sickle cell again. I'll summarize this slide by saying the KAPI, as a representative of the pharmaceutical industry, is a solution partner to help all of us to converge together to achieve this dream, the UHC ambition. And we recognize that we cannot achieve this together, even with our resources, effort, intentions, and energies. We still need the civil society, we still need the NGOs, we need government, we need other elements of private sector to move it forward. And all the initiatives that KAPI is outlining to have achieved has been done in the spirit of partnerships and leveraging synergistic togetherness. Next slide, please. You will find this comment in the report. And the two words I would like to emphasize here is the evolution of the health system and the ideals. Let me read the statement again. KAPI remains committed to work with government and other stakeholders to evolve the health systems towards an envisioned ideal as is espoused in the government's UHC agenda. I emphasize again, we do not seek to overhaul, to deconstruct or reconstruct. We seek to assist, to partner, to support the continuous evolution of the health systems so that they attain ideal status in serving every member of the society. This is the dream, this is a vision, this is the hope of KAPI. And the report is outlining some of the moments and instances that we have managed to demonstrate that. Next slide, please. Now, when Greg spoke, he outlined IFPMA as the global body. KAPI is a member of IFPMA, and we take our partnership flowing through from global to local. And what we can outline here is that almost 50% of all IFPMA programs to advance access to health happen in Africa. And we have over 65 of these in Kenya. And what's more, 40% of these programs, or roughly 40%, emphasize strengthening the health systems, which is at the core of success and sustainability. And we have more than 200 cross-sector inside the nation working our best to attain the dreams of universal health coverage. Move to the next slide, please. And this is which is who we work with. The reason why we work with them is it is the key to unlocking the UHC. Every member of this partnership comes with a different skill set, resource base, capability and capacity to influence directional change. And it is the reason we look at this, that no one person can do it. The government, academia, civil society, NGOs, donors, multilaterals, all of these working together form the fabric. Working separately, we are threads, and we seek to maintain the health of the fabric. Within the healthcare professional body, we strive to enhance capacity through training programs. And KAPI also helps to strengthen and robust the supply chain, procurement, and financing initiatives. We have, in many instances, strengthened the healthcare facilities through provision of equipment and resources. We run a robust disease prevention and programs through engagement with communities. And if you remember a minute back, Anthony mentioned about his team in Taita Taveta Hills trying to create that awareness. This is the genetic makeup of KAPI. And of course, we do strive to increase access to medicines through the sustainable affordability, sometimes through free donations and very flexible pricings as well. Let me move to the next slide so that we wind down fast. We've taken a lot of your time and we appreciate that. What KAPI is doing and seeks to do as a mechanism of ensuring attainment of sustainable development goals and into the next decade is to contribute to creating, not alone, but with others, thus co-creating a conducive health ecosystem and improve alignment and coordination of efforts. There's a lot of efforts in there. And the fact that we brought ourselves together as KAPI is to ensure that we have coherence. We do not over-resource one problem to the detriment of other problems. We hope to continually improve this alignment and also to respond to local needs through tailored solutions. That is to talk to Dr. Eva Jenga and equivalent, to hear the voice of the patient, to create solutions that are appropriate to the needs of the locals. I will go to the next slide. With this slide now, I have concluded in outlining what KAPI is. I cannot exhaust, skip this slide, we will just go to the launch, but as we are going to the launch page, let me do a roll call of honor. It gives me great pleasure every so often to just mention what some of our members are doing as the launch screen is coming up. GSK, that bellwether of dependence, has been decades in supporting the communities. AstraZeneca is large in Sub-Saharan Africa with cardiovascular health. Eli Lilly was the pioneer, almost alone, in helping Ampath to set up their oncology programs. Novo Nordisk has effectively pushed to the extent that insulin affordability in Kenya is real. Merck has been running a Merck for Mothers campaign for years. And if we talk of Merck and company itself, they've had more than 2 decades of trying to end river blindness. If I talk about Pfizer, our member company, and its latest partnership with Gavi and AVACT to advance access to COVID vaccines to Africa at no profit, very recommendable there. Bayer and Boehringer, this is just a few of them, are active in advancing access to cardiovascular health, not just in Kenya, many other countries in Sub-Saharan Africa. That is the roll call of honor I get to call out as a chair of KAPI. It gives me great pleasure. And without any further effort or ado, Esther, please help us to launch the report. That is as much fanfare as we can get in a virtual or digital launch event. Thank you very much, Esther, for bringing that report to formal introduction to the public at large. We will make it available to everyone. If you want to read a copy, let us know how you'd like to access that copy. Under normal circumstances, a launch will be a very comprehensive event, but thanks to COVID and the restrictions placed on us, we are happy to achieve that. I would like to go through a few excerpts here and there about the report, but mindful of time, I will welcome Bwana Julius Karimi from the Ministry of Industrialization and Enterprise Development to give a comment from the CS from that ministry. Remember, as a whole society, in whole total partnership, everyone counts, and the Ministry of Industrialization is the quiet bedrock of achieving everything. We all play within the Ministry of Health, but our base is anchored on the Ministry of Industrialization, and they play a silent but moving role. Let us hear from them what their aspirations are, what their progress are, in a brief comment from Mr. Julius Karim. Bwana Julius, welcome. I wonder, Julius is muted. Can you unmute yourself? Allow me a minute to contact him by phone to see whether I can. He is part of our group. He's in the audience. Julius Kerima, unfortunately, he's muted, and Esther, are you able to unmute him from your side?
Let me just try. Let me try. Julia.
Yes, unmute.
Okay.
No, we can hear you now.
Can you hear me?
Yes, correct.
Thank you, Dr. and thank you, colleagues. I want to step in and give remarks on behalf of our CS who would have really wished to be part of this, and later delegated to the PS who in return put it to me. Dr. Wire Sorene, Chairman KAPI, and Dr. Vinod Guptan, Vice Chairman KAPI, Dr. Wine Nganga, Secretary KAPI, Dr. Angelini Achoka, Treasurer, distinguished sector stakeholder participants, ladies and gentlemen. Good afternoon. It gives me great pleasure to be invited to the official launch of the Kenya Association of Pharmaceutical Industry, KAPI report on collaboration to achieve universal health care. As you may be aware, pharmaceutical industries are the core of provision of health care in all countries. Reliable provision of efficacious and affordable medicine is critical in keeping populations healthy, and the countries are striving to ensure that they have local sources of essential medicines, particularly during such trying moments that the world is going through, with the global supply chains having virtually collapsed, courtesy of the outbreak of COVID-19 and the ensuing travel lockdown. Ensuring reliable access to affordable and quality assured medicine in East Africa community remains a huge challenge. It is estimated that medicines in East Africa are purchased through out-of-pocket payments by individuals. In the region, countries out-of-pocket amount for more than 40% of the private sector health expenditure. And this is particularly critical as a majority of the populations have low purchasing power, which means the decision to purchase medicine is largely influenced by other competing necessities, such as food. In addition to pricing and availability issues, the region is also grappling with threats from substandard and counterfeit medicine, with the WHO estimating that 10% of medicines brought and sold around the world are counterfeit products. And often some counterfeit medicines are dangerous. I note with great encouragement that the Kenya Association of Pharmaceutical Industry, a membership organization established in the late 1960s, represents pharmaceutical manufacturers and their representatives who through research in invent and develop medicines and technologies that significantly improve people's lives. KAPI represents the industry voice and promotes efficiency in the pharmaceutical industry to ensure that the medicinal products and the healthcare technologies are of the highest quality, and they can be readily available for diagnosis, prevention, and treatment of diseases. This is indeed commendable. Ladies and gentlemen, the East African community currently imports about 70% of its medicine requirements, and it is a priority for the region to change this over reliance on external sources for our essential supplies on matters health. The second EAC Regional Pharmaceutical Plan of Action 2017 to 2027 is a regional roadmap to guide the East African region towards evolving an efficient and effective regional pharmaceutical industry that it can supply national, regional, and international market with the efficacious and the quality medicine. Among the targets of the plan is to decrease the dependency of the pharmaceutical imports from outside the region, to support the expansion and the productive portfolio of East African farms to cater for more than 90% of the disease conditions, to have at least 5 more farms producing more advanced formulations, such as delayed release formulations. To achieve these targets, a number of key strategies have been prioritized, and among them is putting the regional farms on a GMP roadmap to ensure that manufacturers upgrade and attain internationally recognized quality standards. The region also is implementing an incentive package and appropriate financing schemes for local pharmaceutical manufacturers. In Kenya, colleagues, you may wish to know that under the Buy Kenya and Beyond Kenya policy, the government is promoting local procurement of locally made pharmaceutical products and devices, pharmaceutical products, including the devices. There is also emphasis in establishing a regional framework for mutual recognition and harmonization of registrations of medicines. Overall, the strategy aims at ensuring that the local industry thrives and is able to cushion the region from being so much dependent on external sources. Colleagues, we all know that the region, the rest of the developing countries, we are still queuing for vaccines as the developed world serve themselves. So this is a time, even for Kenya and the EAC region, to consider coming up with a production of human vaccines You are also aware that Kenya is progressively being weaned from support for human vaccines by Global Alliance on Vaccines and Immunization. And as that momentum peaks, it is time also a KAPI and the partnership of the sector considered coming up with a local manufacture of vaccines, including COVID-19. Ladies and gentlemen, KAPI should be at the forefront in advocating for a national research agenda, which aims at coming up with homegrown solutions to the common ailments that afflict our people. The association should be at the center stage in forging and strengthening collaboration between academia, industry, and the policymakers with a view to creating synergy for enhanced performance. This is part of the area where we come in very well. The ministry has been at the forefront in trying to forge and strengthen this collaboration between academia, industry, and the policymakers, such that the skills requirement for industry, for example, industrial pharmacists, can be provided for in our institutions of learning, so that as they come out, they hit the ground running. We want also appeal to industry to account attachment to the graduates, so that they can have practical skills. And together with the policymakers, we want to move in tandem so that the policies that are being crafted are supportive of the industry in its totality. Academia must be flexible to address the fast changing skills needs for industry amidst an equally changing health needs landscape. We should now be considering local manufacture of human vaccines to cater for the country as we progressively get ready from support by Gabi. Colleagues, with these remarks, I want to thank you most sincerely for extending the invitation to the ministry to join you during this important occasion. Thank you.
Thank you very much, Bwana Julius Kirima. We, as I mentioned to the members and the audience, the fabric to success in universal health coverage includes everyone, every input, and I'm very happy from my previous engagements and activities with the Ministry of Industrialization. They've been very vigilant and shown capability to advance access to universal health coverage from their own dimension, which focuses a lot on improving access, improving ease of business to attract investors who bring health solutions, to pitch and advance manufacturing, and indeed the realization of the pharma industrial park within Konza City is an example of the effort that the Ministry of Industrialization has pushed to attain more pharmaceutical and medicament independence for Kenya. Now, with our time being overshot by over half an hour, I feel unless we have a specific question or feedback, I would like to invite our Honorable Secretary, Madam Winnie Murangi, to do the honorable thanks and closure of the meeting.
Thank you, Willie. You can hear me and you can see me?
Yes, we can hear you.
Proceed. All right. So, CAS, Dr. Mercy Mwangangi, PPB CEO, Dr. Fred Sioi, Julius Kirima from the Ministry of Industrialization, IFPMA, KAPI Chair and Board, our speakers today, distinguished delegates. I'm sure I speak for everyone when I say this has been an informative and insightful session that has culminated in a successful launch of the KAPI report on collaboration to achieve universal healthcare and health system strengthening. It would not have been possible without each and every one of you. I know we've run over time, but we thank you for staying with us all through to the end. We are highly privileged to have had the honor of our key guest, CAS Dr. Mercy Murangi, and our valued partner, Dr. Fred Sioi. We don't take it for granted that you graced our occasion, and we greatly appreciate. We are living in the best of times, whereby true collaboration, private and public, is becoming a reality through events such as this. CAS Dr. Murangi has been in the forefront of designing and implementing UHC program, as she mentioned earlier. Therefore, hearing her speak today on this great occasion, and on specifically on the role of partnerships and collaborations in advancing and accessing and attaining UHC, is truly a positive call to action to us as stakeholders. And it's a clear indication that there is room for more partnerships as we are having and we are moving in one mind on a focus of Wanjiko the patient. PPB has been a valued partner, and Dr. Sioi has been a pioneer leader in advancing quality, efficacious, and safe products in the market. And his approach towards collaboration with private and public has been unique and greatly appreciated in the industry, and furthermore with UHC. And today he emphasized that everyone's input is valued, whether big or small, and we appreciate that. Ministry of Trade and Industrialization, Julius Kirima, has just challenged us as KAPI to be at the forefront in collaborative efforts, and specifically academia and local manufacturing. So I believe there is room for us, and we accept the challenge, Julius. A big thank you to our speakers, Greg Perry, collaborate on the global perspective of UHC. He was able to highlight a realistic scenario with how this has translated in the COVID management. And Dr. Eva Jenga from the NCD Alliance highlighted the shortcomings and opportunities in UHC from a patient perspective and areas of leveraging on key partnerships. I think there lies another opportunity which we will embrace. Mr. Anthony Murangi from Novartis, he gave a good flavor of what the access programs that are being run by a KAPI member company. And this just gives you a taste of what KAPI has to offer in support of UHC. And also Dr. Karim Bendao on Africa UHC reports, he focused a lot on the role of the private sector on sustainability and development. These speakers indeed have set the pace and have set the scene for the launch of the KAPI report. We'd also like to thank IFPMA for the great support you have offered in the development of the report and its eventual launch, and all the planning that took place behind the scenes. Thank you to Greg and his team, Charles, Belinda, Paloma, and everyone else. To the KAPI board and the KAPI chair, Willie Sorine. As you can see, he's a great facilitator, and he's made the session very interactive. And also through his leadership, this noble initiative has been made possible. We won't forget our admin, Dr. Esther Nyango. She's been very capable and able to work behind the scenes to make this a reality. She's responsible for the razzmatazz that you saw there in the actual launch, and thank you for that, Esther. Last but not least, to the delegates and the attendees who have stayed on and who also have been there throughout the session, we truly thank you. And as we close, I'd like to leave you with this quote from Henry Ford. Coming together is a beginning, keeping together is progress, and working together is success. With those few remarks, thank you and enjoy your evening.
Thank you very much, Madam Secretary.
Thank you very much.
All right. Bye-bye.
Bye-bye.
Thank you. Goodbye.
Thanks.
Thank you, everyone. Bye-bye.
Bye.